Okay, well, welcome everyone. This is, I believe, our fourth webinar that we're doing in this series of 8. My name's Al Rundio, and I, along with Connie Mealy and E.M. Garcia, we are the ones that have put together this 8-hour program. And tonight we'll have Connie Mealy presenting. She's logging on right now. So first, I want to talk a little bit about the American Society of Addictions Nursing. This organization was created within the past year. And we really thank our sponsors, and our big event sponsor for this is Suzanne's company, who really are sponsoring the whole webinar platform, the Zoom platform that we have. And that is Recovery Management Solutions. We know them as FSS Solutions, and they're a wonderful company, and we appreciate the fact that they are the ones that are sponsoring the Zoom platform for our webinars. So welcome to the program. You're welcome to keep your cameras on so we can see you. You definitely want to mute your microphone throughout the program, because when people are talking, it really does interrupt the presenter, and it interrupts others from hearing what the presenter is presenting. You want to post your questions in the chat box, and I'll moderate the session that Connie presents, and we will go through the questions at the end of the presentation, and I will read her each question, and then she can respond. You will need to complete a session survey. They are available right on the ASAN website. It's on the schedule page there. And when you complete the survey, which really takes probably 5 minutes or less to do, when you hit send, you automatically will get your contact hours certificate. This entire series is worth 8 contact hours. You get 1 contact hour for each session. And I was ahead of myself. And again, the certificate will come right to your email. I did a couple of them today, and as soon as I was finished, it was right in my email. All of these sessions are also being recorded and archived on the schedule page for viewing if you're unable to participate in the live session. So if you are unable to make one of the sessions, but you want to watch the recorded session, you also would complete the survey and get contact hours for that as well. And then I wanted to introduce you to our ASAN Board of Directors. Our president is Bill Carrick. He presented last week. Our vice president is Susanna Looney-Kinkle, and Susanna and I were just chatting. Our treasurer is Bill Lorman, and our secretary is Virginia Coletti. And then our board of directors are Carolyn Baird, Fran Campbell, and Mary Armstrong. I'm not even going to try to pronounce her last name, Fogier. The webinars have been every Tuesday at 7 p.m. Eastern Time. Today is Connie Mealy, who's presenting on opioid substance use disorders. Next week, week 5 on August 3rd at 7 p.m., Adam Barrett will be presenting on stimulant and other substance use disorders. Week 6, August 10th, is Dr. James Ferguson, who will present on laboratory tests for substance use disorders. Week 7, which is August 17th, which is common psychiatric disorders, and that will be Diane Snow and Virginia Coletti. And on week 8 will be myself presenting holistic addiction treatment services. So today's session is being offered by Connie Mealy. The learning objectives, as you can see, are understand the disease process of opioid addiction, describe the opioid epidemic, discuss the impact of the pandemic on opioid disorders, and understand the medications used for medication-assisted treatment, as well as other treatment options. We want to say a big thank you to our presenters, our attendees, and of course, our sponsors, and hopefully we'll see you back here next week on week 5, Tuesday, August 3rd. And if you're not a member of ASAN, I would really encourage you to join this great organization. With that said, I'm going to stop sharing so Connie can share her screen and load her slides, and we'll let her take over.
I hope everyone is having a good day. I don't know where you're from, but it is hotter than Hades here in North Carolina. And what I want to talk about tonight is the opioid addiction and issues that we have in this country. In fact, if you were listening to the national news in the last day or so, they have been talking about how it has continued to grow. It is not getting better. The pandemic was not stop to the issues we had with opioids. They just continue to get worse. So what I want to do is, one, I want to give credit to NIDA because a number of the slides that I'm going to be using are from them. So that's what this slide is. So, you know, again, I don't know who is on the call and how much experience or expertise you have, but I wanted to lay some groundwork before we got into some of the specifics about opioids and just talk about substance use disorders and help people to, you know, understand that, you know, it is a brain disease, not a weakness of will, not a moral issue, but a brain disease, and people's brains are changed by the use of alcohol or drugs. And again, perfect scan here of showing a healthy brain and a brain that has been affected by drugs. I do want you to realize that, you know, and we certainly are getting lots more funding federally and locally and state governments for the opioid epidemic in and of itself. But, you know, a lot of times the money that we're given while targeted for opiates these days, and is certainly more than we've had in a long time, many times very little money that we get goes directly towards treatment and prevention. It goes towards some of the consequences, some of the drug interdiction kinds of things. And so it continues to be a underfunded initiative compared to the number of people who are dying from it. And we'll talk about why that is. Just a couple of statistics, because I think they paint a picture better than anything. But looking at, in this particular case, the use of pharmaceuticals and how it increased the overdoses of people from 2007 to 2011. Again, another one in regards to women, that it increased more than 400%. Since 1999, and that is deaths for women compared to 265% for men. And so some of the statistics that we've been seeing lately is the overall drug overdose deaths, which have resulted in 247,000 deaths, and that prescription drug-related deaths in 2013 outnumbered all other kinds of deaths, motor vehicle deaths, car accidents, firearms. And as we know, the sale of prescription painkillers has, you know, quadrupled over the last year. And, you know, again, I think that we live in a society of quick fixes. And if I don't feel well, then I'm going to go to the doctor and get something for my pain, for my cold, whatever's bothering me, because I don't have time to be sick. And so when people go to the doctor, the expectation is that they're going to get a prescription for something while they're there. And so again, when doctors have limited time to see patients, the easiest thing for them to do is to prescribe something for that person. And as we know, those of us who work in the field, you know, the amount of misuse and abuse and addiction of drugs costs billions of dollars to our country every year, not only in medical costs, but social justice and work, employment, legal, all those kinds of things. Just a couple of stats for North Carolina. 5 people die from opioid overdoses every day. And again, more than 2,000 died of overdoses in 2017. And again, you know, the unintentional opioid deaths in 2017 were 17 is higher. So again, just wanting to paint the picture that, it is an issue, and, we're getting to the point where just about everybody knows somebody or knows a family that has been affected by the opioid epidemic. Again, number of unintentional opioid overdoses. And again, we're continuing to see that rise. So, there's a lot of myths about drug addiction, substance use disorders, whatever you want to call it. The new term is substance use disorders. But the idea that drug abuse is addiction, it's not. There is use of a drug, misuse, abuse, and addiction. Many people think that alcohol is not a drug. And as you heard last week from Bill's presentation, that certainly isn't true. It is a central nervous system depressant. It just happens to be one you can buy in the corner store and purchase yourself. You don't need a prescription. The idea that if you were just stronger, if you had more willpower, if you loved your family more, you would be able to stop using alcohol or drugs. And as I'm sure you learned in the presentation on neurobiology, that, there are changes in the brain and an obsession and compulsion that, keeps the person continuing to use and seek out drugs. The having to hit rock bottom, you don't have to lose everything. A person, can be interested in treatment sooner rather than later, and we can elevate a person's bottom. If in fact the person's family is important to them and the wife says she's going to take the kids and go, or if the person is a nurse, for example, and is reported to the peer assistance agency and told, if you don't stop and follow the recommendations here, you could lose your license. So we can elevate a person's bottom so they don't have to lose everything. And, that is what we try to do, because we don't want people to have to lose everything. But as you can imagine, there is a stigma attached to being a person with a substance use disorder. And so it's a hard thing, to admit. But I have to say, I've been doing this work for, over 40 years now. And I have yet to meet an alcoholic or a person with a substance use disorder who said, I woke up one morning and just decided I wanted to be an alcoholic. I wanted to be, a person with an opioid disorder. Nobody wants to be that. And again, we'll talk a little bit about what contributes to the development of that. And, again, the misnomer that drug abuse and addiction is more common in minorities. We know that's not true. And this was just a quote that somebody from one of the deputy sheriffs about, helping people understand that it can happen to anybody. In fact, when the opioid crisis was beginning, people were talking about the soccer moms who were addicted to Vicodin and OxyContin. And so it can happen to anybody. I think for us in the healthcare professions, we have a hard time if the person doesn't look like what we think a typical alcoholic or drug addict or person with substance use disorder should look like, then while we may have lots of evidence that the person may have a problem, we have a hard time talking to them about it because we know that they're going to be defensive and, heaven, what if I'm wrong? Which, typically you are not, for sure. But, it is an illness that can affect anyone. I think that people forget that substance use disorders contribute to deaths, AIDS deaths, from sharing needles, et cetera. And I think, people don't equate the two together, but, we have certainly seen that. Again, just an illustration of, lots of discussions in states about the legalization of marijuana, pros and cons, all of that. And yet, we still know that marijuana is typically, for many people, the first drug that they used before they moved on to stronger drugs, such as opioids. And again, why do people take drugs? You know, to feel good, to feel better, to do better, to feel different, curiosity. And again, you know, it's typically always to change the way the person feels. I either don't want to feel anything at all, or I want to feel different. And alcohol delivers, and drugs deliver every time that I use them. They will make me feel less fearful, less stressed. They'll allow me to, relax. So again, when we're younger, we tend to do it to feel good and figure out what all those things that people are talking about, what are those feelings like if you've never had those feelings. And then as we get older, it has a lot to do with handling life's day-to-day kinds of things and what's going on. Oops. I won't spend time on this because I'm hoping that you heard Bill's presentation on neurobiology, but again, we're talking about the limbic system, the amygdala, and, that area, that pleasure pathway in our brain that gets lit up when you use alcohol or drugs. I put this one in because I think people forget that kids' brains continue to develop into their early 20s. And, I think many people think by the time they're 12 or 13, their brains are fully developed, and they're not. And so when kids start using drugs sooner, then the impact on them is significant, especially on a brain that is continuing to develop. So talking about, targeting the brain's reward system by flooding it with dopamine, and here's an example of with cocaine and or food, that any of those things that feel good, so whether it's food, sex, gambling, alcohol, drugs, that takes part in your brain's pleasure pathway and makes you want to do it again. A number of years ago, Time Magazine put out this issue that was all about getting addicted. And I think it was extremely graphic and descriptive. So wanted to share that. And again, we're talking about engaging, the pleasure pathways of the brain. So, what is drug addiction? What is opioid addiction? It is the obsession and compulsion to use in spite of negative consequences, and whether those negative consequences are work, family, legal, physical. So it can be any of those, it can be all of those. But as this definition talks about, it is also chronic. So once an alcoholic or an opioid addict, always an alcoholic or an opioid addict. The difference is whether a person's in recovery or not. And so the relapsing part of that is that people do sometimes relapse. Not everybody relapses, but many people do. But, the purpose of this slide is to show you a healthy brain and one that is a cocaine abuser and see the differences, and then to show you a person's healthy heart and a diseased heart. Because what I'm showing to you is diseases that have behavioral components to them, such as heart disease, high blood pressure, such as diabetes, asthma, are diseases that can be improved and have less of a negative effect if you do the behavior changes that you need to do. And we know that you've all read articles and may have been on a program of some type to become healthier. And so the idea is that since substance use disorders are diseases of the brain, it's not really any different than whether it's a disease of the pancreas, whether it's a disease of the heart. People will have them for life, and they have a choice of how they treat them, whether by behavioral changes, medications. But again, in the definition of drug addiction, it is around the obsession and compulsion to use in spite of negative consequences. So, we know that there are two factors that contribute. There's genetic factors and there are environmental factors. And so we know if you come from a family where there's substance abuse, substance use disorders, alcoholism, you have a 2 to 4 times greater chance of developing the disease. And sometimes it's the uncle or the aunt that somebody doesn't talk about, or you don't go visit, whatever that may be. I had been working in the field for probably 8 or 10 years and had on a regular basis asked my mother if we had anybody, because I wasn't aware that we had anybody in our family. And she assured me we did not have anybody in our family with that disease. I thought, oh, okay, that's really rare, but okay. And then my mom was terminally ill, and I was up in Ohio taking care of her, and we were driving around the little town I come from, and we drove by a street that's named for my great-grandfather because he had a big farm. And I said something like, well, isn't that nice that they named that for? And she said, yeah, it's just too bad he was such a raging alcoholic. Well, you can imagine, I was in the front seat in a moment because I asked her numerous times and she said, we didn't know anybody. And, what she said was, you didn't know him. And I didn't want the only thing you knew about him was that he was a raging alcoholic. And I said, yeah, but I like alcoholics. That's the work that I do. So again, we know there's a genetic predisposition. And I found some articles that talked about the fact that there are 89 genes, and there may be more by now. I researched that several years ago, that are linked to substance use disorders. Now, for those of us in the field, that's kind of exciting because we could do blood work and see. And so if somebody comes back and they have 2 of the 89 genes, they certainly have a less likely chance of developing the disease of substance use disorders. However, if they have 78, they have a pretty good chance. And so we could at least help people make informed decisions. And again, this would typically be with kids, which, would be the time to really try to interrupt them beginning their experimentation and having an issue at a young age. So then, the other part is environmental factors. What happened to you early in your life? And was there early physical or sexual abuse or emotional abuse? Children witnessing violence. We know that kids who witness violence and end up with trauma have smaller brains, and they have more dead space in their brains, and they are more likely to develop psychiatric and or substance use disorder. And so one of the programs that we developed was where we paired a social worker in every police precinct so that if an officer got a call and went out and there were children who witnessed whatever the crime was, then our social worker went out and started working with the kids immediately to try to interrupt that and help them process what happened and deal with it and put it in its proper place. And so that was a really successful program. But it's a hard program to run from a county perspective. And you end up seeing lots of kids who have lots of needs. If you want to be in the in crowd and the in crowd happens to be a drug using crowd, then, you want to fit in. And so you'll use alcohol or drugs. And the last is drug availability. When I worked at a methadone clinic, a lot of parents just kept their works and stuff on the coffee table, in full view. And again, if you grow up in a family where, anytime there's a problem, we need to get a prescription medication for that, then that's what you grow up thinking, that, I've got to get some kind of pain reliever for this. And so again, a lot of that, we get in our families. All right. And this slide is just really to drive home that no single factor determines what a person, whether a person will become addicted or not. And the graph or picture kind of shows you there's many different things that contribute to that. You could take two people, same age, same sex, and start them using the same drugs at the same time, and could be a very different trajectory for both of those people. I think for us in the medical field and nursing field, that's what's most frustrating, is there's just a lot of gray. And that's, because everybody's different. And then to go back to the relapse question or statement, I just wanted you to see, here's some examples of relapse for people. And, substance use disorders is not the top one. And so, we're looking at asthma and hypertension. So again, it doesn't have to be a life sentence. You can recover or be in recovery. You're never recovered, but certainly you can survive a relapse and move forward. So, this question is, what responses have you received from your patients when you told them they had a substance use disorder? When I worked in for a clinic, an outpatient clinic, and I went to the hospital to see patients, never did anybody go, oh, really? Oh, that's what the problem is. Okay. What do I need to do? You were immediately told all the reasons why they couldn't be. I've never missed a day of work in my life. I'm still married, I couldn't be an alcoholic or a drug addict. And so again, the reason that people respond so negatively is because of the stigma that's attached to, in my opinion, any disease that we have above the chin that has any behavioral component to it. That's just, people just are lazy. They're not willing to do what they need to do. They don't love their family enough, whatever the things are. So, the idea is that instead of judging people, how can we help them? And I like the word carefrontation versus confrontation, because again, I think that carefrontation means we're doing it with care and understanding and wanting to meet the person where they are. So again, just a slide to show the shame that people have, the guilt, their life is over. And, the other part is drugs and alcohol become the person's best friend. It delivers what it promises every single time, which is not to feel anything at all or to alter how I'm feeling. So there is a huge fear of, how am I going to live without alcohol or without drugs? I mean, I can't fathom what that would be like. And so there's also a grief and loss process for that. So Bill Clinton said this, and, I think it's so true. And we need to remember that, having mental illness or behavioral health disorders, nothing to be ashamed of, but stigma and bias shame us all. And so again, what does stigma have to do with the person suffering? It prevents them from accepting that they have a disease, that it's a treatable disease, and so therefore they don't seek treatment. There could be social and legal ramifications if they do. Just recently was working with a pilot. And so again, it's hard to admit that you need help. And so, what are some of the things that you can do, to address it? I mean, you have your choices, which is to ignore it, hope it goes away, tell a person that they need to cut down, or tell them they need to quit. And again, when you look at someone who has the disease of addiction, if they knew how to cut down or knew how to quit, they would have already done that. And so, it's important that we address it when we see it. Because even if the person doesn't do anything about it at that moment, at that time, still it is, you're planting a seed that may not grow today or next month or next year. But believe me, that patient will remember what you said and what you were concerned with. And so again, many tools for addressing it. So one of them is SBIRT. We're not going to go into this, but it's screening, brief intervention, and referral to treatment. It's something that can be used in clinics, in the hospital, in emergency rooms, and it is a way to begin the process of helping someone move forward with being accepting of treatment. I'll allow you to read and look at these at another time. Just wanted to give you the tools. And then the other part is just the stages of change. It is not unique to people with addiction that they go through stages of change. We all go through stages of change when we decide to make a change. And so again, there's the pre-contemplation and the contemplation that maybe someday I'll do something, and then beginning to take the steps and then doing it, the whole maintenance part, and relapse. And so, this is a process that many of us go through. And Prochaska and DiClemente did some great work in articulating this. And so again, how can we help the person who may be in pre-contemplation decide that, it's time to start thinking about maybe you need to make a change? Because actually, if we go back to that, the other piece of it is, what if I don't know how to change? What if I so identify with what it is that I can't imagine who I would be if I wasn't that? Again, motivational interviewing, very important. Again, meeting people where they are, trying to get them to begin to make some changes and see how they're doing with those, along with, partnering with the patient and following the ACE, the autonomy, the collaboration. And again, trying to get them motivated for change, because as you know, if you're not motivated to change, you're not going to stick to whatever it is. So what is the person's motivation to have a different life? Okay, so, what's different? Opioids, when we talk about opioids, we're talking about drugs that come from the poppy plant, date back a long time, again, used for medicinal reasons, and typically are street drugs like heroin. Opiates is the synthetic versions of them. They're man-made, and they're typically prescriptions like Vicodin, OxyContin, and those kinds of things. And why do people use opiates? To relieve pain, typically. And so again, looking at how it, the pain medicine goes to the nervous system and then to the receptors and to the spinal cord and finally to the brain, and a person gets relief. And so again, that's the expectation. If I'm having pain or discomfort, I need something for that. So, the opioid epidemic kind of, I think, became the perfect storm. Because in the 90s, JCAHO decided that we weren't treating people with chronic pain effectively, and we were leaving people to suffer. And so they made pain the fifth vital sign. And so again, every time you enter a room and you're doing a patient's vital signs, you also say, are you having any pain on a scale of 1 to 10? What is that? Oh, it's a 7. Okay, well, I've got something I can give you for that. And we just kind of did it rotely. It was just kind of, your blood pressure is this. Are you having any pain? And so we started medicating people. OxyContin became approved by the FDA. And then, started the real crunch on physicians in regards to how much time they had per day with each patient that they saw, because they were expected to see X number of patients. So depending on what that number was, it would be 9 to 14 minutes that they had with a patient in their office. Well, as you well know, that is not a lot of time to have a patient articulate what their issues are and be able to look at many options. Is physical therapy something that you could do? Or, is it the chair that you sit in at work? Or, is this arthritis? And so physicians, it's easiest to write a script. And so physicians and nurse practitioners, physician assistants, are put in a bind of trying to meet the patient's needs. At the same time, the patient comes in with the expectation that I'm going to get something for pain that will relieve this pain because it's interfering in my life and I have many things I need to do and I can't work when I'm in this pain and I have to work. And so you need to give me something for that. Along with what kind of dovetailed with that was that there were patients who were, rating their physician. And, physicians' quarterly bonuses were predicated on good evaluations from patients. And so you can imagine if someone came in and wanted an opiate of some kind, and the doctor said, no, I've written you 2 prescriptions for that. And we've talked about, you need to try physical therapy, and I'm not going to prescribe you any longer. That person's not going to give the physician a good rating. And so physicians again were, and physician assistants and NPs were in a difficult spot. And then Vicodin, came out and, it was touted as non-addictive. And so, let's just prescribe that for everybody. We won't have to use OxyContin. We can go ahead and do Vicodin. And along with that, again, we're a society of quick fixes. And so the expectation was that, I would get something for my pain. So all of that together certainly set us up for there to be an opiate epidemic in our country. Just a comparison again of how much money was spent on prescription drug sales and scripts. And you can see how significantly it went up over time. And then I'm sure you all have heard these statistics, but again, paint a good picture. In 2012, there was a bottle of OxyContin for every adult American. There were over 259 million prescriptions available floating around in people's homes. And for younger people, one of the things to do is to have a party and a bowl at the front door, and people just drop in. The price of admission is you need to bring, a handful of pills of some kind, and you just kind of drop them all in the bowl, and then people just decide what they're going to, a handful, how many they're going to take, not having a clue about what any of those may be. And so, again, significant problem. So one of the recent studies I read, the demographics were, it is typically white men who have high rates of addiction to opiates, who do not have any college education. Women have higher rates for overdose. And then, of course, we've heard of the Appalachian Rust Belt and some of the higher overdose rates there. And then we know that it's easier to mix fentanyl with the finely powdered heroin of the East Coast versus the tar heroin on the West Coast. Not to say that both of those types of heroin don't exist on opposite coasts, but that is what we see more of. So, I guess you could say, some good news is prescription overdoses are down. As we all know, the prescribing practices for physicians and NPs and physician assistants are very prescribed now, whether the person has an acute pain issue or a chronic, and only so many prescription can be written, only so many pills per prescription, et cetera. Though I will tell you that recently I had one of my dogs who had an older dog that had some issues, and so went to the vet, and she was put on tramadol, which we did have to go to the CVS and pick up. And she got tramadol 100 tablets with 6 refills. So, again, a big incongruency there. So the non-prescription overdoses are up. And again, that's typically where we're seeing the opioid with something else, or that they've used something in addition to the opioid. We certainly have seen an increase in the neonatal abstinence syndrome. And again, typically what a baby born every 15 minutes. And again, this epidemic's been rising faster than the HIV/AIDS epidemic in the 90s. And yet, we're still continuing to struggle to have enough dollars for treatment and medications and whatnot. So again, harm reduction, for those of us who've worked in the field a long time, of course, we kind of grew up in the field of, abstinence, recovery, 12 steps, all of that. And all of that is very good. But we also need to be realistic that in some cases, especially from a public health perspective, we need to be focusing on harm reduction. And again, meeting people where they are. So I know here in North Carolina, we have some needle exchange programs. We do not have any injection sites that I'm aware of. And again, injection sites are just that, where you can go and inject and be in a safe environment should you overdose. And there are people there who can help you if you start to overdose. And the needle exchange programs are just what it says, exchanging dirty needles for clean needles. And then medication-assisted treatment. When I worked at the methadone clinic, and this was many years ago, I had a client come in because I had just started working there. I'd been in a step-down unit from coronary care. And a client came in who'd been diagnosed with hepatitis B. And then his friend came in and said that, he had hepatitis B. And I said, really? Where did you get checked? And he goes, well, he said, I didn't. He said, but, John has it. I said, yeah, but, again, naive me, but you can only get that if, you were sharing needles with him. Like, I thought they would never do that. So again, the things that you learn as you work in the field. So, basically we have a couple of medications that we use for opioids, for medication-assisted treatment. I don't know what your belief and philosophy is about medication-assisted treatment. There are some very strong feelings in the field about them. I've been in the field long enough now that, quite frankly, I don't really care what somebody uses if they can get off drugs. And begin to resume somewhat of a normal life and, maybe be a contributing member to society and get back with their family. So again, my introduction to substance use disorders was working in a methadone clinic with hardcore addicts. And I learned early on that I really liked working with them. And in our clinic, which I don't think was different from many others, people were on a dose that they did not get high from. It only kept them from going through withdrawal. Our doctors didn't give high doses. And so, it is a long-acting medication, and it alleviates cravings and withdrawal symptoms. And if you've worked with hardcore opioid addicts, their biggest fear is going through withdrawal, because again, as you see, the side effects here, nausea, constipation, sedation, the withdrawal is, if you think of the worst intestinal flu you've ever had and maybe magnify it, 3 or 4 times. I mean, that's what withdrawal from methadone feels like. And with withdrawal from opioids feels like. And nobody, wants to feel that way. And it's going to last, usually 5 to 7 days. And usually by the third day, when I've run detox programs, is when the patient says, I can't take it anymore. I got to get out of here. And so, some places use Klonopin for withdrawal, treat the symptoms, the leg cramps, the stomach cramps, the diarrhea, basically just treat what those symptoms are. But, it's a difficult withdrawal. Now, just, withdrawal from opioids, you don't die from opioid withdrawal unless you have other things on board besides opioids, but it's not a pleasant type of withdrawal. It's not like alcohol. You can die from alcohol withdrawal. Oops. All right, so the other choice, something that came along, and I will tell you that people refer to methadone as kind of the blue collar medication assisted treatment, and buprenorphine and Suboxone are, the white collar, because you can go to the doctor's office and get that. So again, taken daily. There is a implant that's available. The risk of overdose is less than with methadone, and its withdrawal is less uncomfortable than methadone. And you have to participate in a treatment program, which you have to do with methadone as well. And there, if I can step back to the methadone for a minute, the other part of that is that there's discussions about how long you can stay on methadone. And so typically it's around a year. But there are people who have remained on methadone for a long time. And I can tell you that some of the hardcore addicts that I worked with, I really couldn't see them getting off of the methadone. And they returned to work, they returned to their families, they were contributing members to the community. And so again, we need to be careful about our judgment of people who may choose to use medication to help them get clean and sober. So again, buprenorphine is another option for people. And then naltrexone, which blocks the effects of opiates. You can't take it for 7 to 10 days after your last opioid usage. It's not helpful for withdrawal. And I know there are treatment centers that are using the extended release injectable, which is Vivitrol, so that it lasts for 30 days. And, they're suggest it helps with cravings. Obviously, it helps the person get through that momentary urge to use because it's in their system. And it's interesting because some places, treatment programs that use it, do not consider it to be medication-assisted treatment. They consider it an adjunct, and it doesn't give you any effects, and so therefore it's okay. But those same places will say, well, we don't use medication-assisted treatment, and I have to go, well, that's not really true. And then we know about naloxone, and again, depending on where you live, there are pharmacies that if you pick up an opiate prescription, they will give you naloxone or ask you if you would like naloxone to have with it and explain why. I think every treatment center should certainly be talking to their patients, especially if they're an outpatient program. And then when patients are getting ready for discharge, to have this on hand. I can't tell you the number of clients that I've worked with whose families did have it on hand and did use it. And then, of course, the other families that didn't really understand about it. And I think, again, from a public health perspective, we should be helping people to understand that and why there should be naloxone pretty much everywhere. All right. I know I'm running out of time. So the one thing I wanted to also just touch on is the social determinants of health, because if you have a patient who's not doing well, not following through, having issues, what is going on with them? Do they have a safe place to live? Do they have food to eat? Do they have transportation to get to the outpatient clinic? A lot of times we think people are just being obstinate and not responsible, when in fact, there are many social determinants of health that are causing them to be where they are. So again, treatment works. And so whether the person wants to go to an inpatient program, which can be anywhere from 14 to 90 days with an extended care component, possibly an outpatient program, which is usually 12 weeks or so. There are some people who go through inpatient and then outpatient. All of those work and are effective. There are people who go to Narcotics Anonymous or AA, even though they may be using opioids, and get their recovery by going to the meetings and doing what they're told to do there. So again, wanting you to know that, people do get well, and, we just need to be able to recognize that people have the issue, and then help them find what is the most effective form of treatment for them. So again, here's a picture of a meth abuser's brain and how, it did get better with abstinence. So again, here's a description of different types of treatment, what can work, and where you can find medication-assisted treatment. And the last thing I just want to say is, as nurses, we tend to think that this just happens to everybody else and it can't happen to us. And it certainly does happen to nurses. And so please, if you're working with someone and there seems to be some issues, let your nurse manager know, so he or she might be able to talk with the nurse and see what the issue is before she or he gets too sick and maybe overdoses, and hold another lecture on that. And there's the references and again, resources. There's lots of 1-800 numbers. NIDA and SAMHSA have those to help you get to treatment. And here's my contact information if you have any questions or comments that I can help you with after the presentation. I think that's it with a minute to spare.
Connie, that was excellent. Thank you so much. So if you do have questions, please post them in the chat box and I will let Connie answer them. Any questions?
And it's
Actually,
okay if there's not.
Yeah, I think you were extraordinarily clear and very thorough. So, I think
Thank you.
that's why you wouldn't see a lot of questions.
Okay. And again, I would just like to.
Here's
Okay.
one. Do you see resistance to AANA for people on Suboxone?
Yeah. In fact, I had that thought go through my mind while I was presenting on that slide. Yes, I do. And so one of the things that's happened here in Charlotte is they've started their own AA and NA meetings, and because they really did feel like they were ostracized, or they go to the other meetings and just don't share that they're on Suboxone, and that's okay too.
And a lot of comments saying, great presentation. Thank you.
Thank you.
Okay. Well, thank you everyone for being here. Don't forget, next week, same time, same place, Tuesday, 7 p.m. Adam Barrett will be presenting on stimulant disorders. Have a great week, and we will see you next week. This webinar is recorded. It will also be available for anyone to watch it on the ASAN website. And don't forget to complete your survey so that you can get your contact hours. And again, if you're not a member of ASAN, please consider joining. It's a great organization. We're growing by leaps and bounds and plan to do a lot of these webinars monthly. Take care. And again, thank you, Connie, so much.
Thank you. Good night.
Good night.